Okay, if you're in medicine, especially if you're just starting out, you know there's one question that can be tougher to face than almost any other. So today, we're going to break down the science and the art of a skill you absolutely have to have, estimating survival in terminal cancer. Let's get right into it. Right? This is the one. The question that just stops you in your tracks. It comes from patients, from their families, and it's one of the most critical pieces of information you will ever have to give. It literally shapes everything that comes next. Treatment choices, end-of-life planning, those final goodbyes. But man, getting it right is just notoriously difficult. And when I say difficult, I mean we can be way off. In fact, one really important study found that, on average, doctors' predictions of survival were 5.3 times longer than how long patients actually lived. Think about that. That's not a small margin of error. It's a huge gap that points to a fundamental challenge in how we provide care. So, what's going on here? This isn't just about, getting the math wrong. The evidence really points to something more like a systematic bias, a kind of optimism epidemic that affects how we think about a patient's prognosis and, maybe even more importantly, how we end up talking about it. Now check this out. This slide really breaks down that optimism in a fascinating way. A landmark study asked hospice-referring physicians for 3 different numbers. In their private, honest-to-goodness clinical judgment, they estimated a median survival of about 75 days. But when they were asked what they would actually tell the patient, that number jumped up to 90 days. But the reality? The actual median survival was just 24 days. A massive difference. And you have to understand, this gap isn't just some interesting piece of data. It has profound real-world consequences. When we give an inaccurate picture, we can accidentally rob patients and their families of the chance to make truly informed choices about their final months, weeks, and days. And this right here, this is the result. A major systematic review found that here in the US, less than half, only 49%, of patients with advanced cancer actually understood their prognosis correctly. That means over half of these patients are walking around with a completely different understanding of their future than their own medical team has. Okay, so if our gut feeling is often way too optimistic, how do we get better? Well, the answer really lies in moving beyond just our intuition and grounding our estimates in objective, evidence-based predictors. Let's take a look at how we can start building a more accurate picture. This quote from the research really just nails it. Our intuition and our clinical experience are valuable, for sure, especially when we combine them with other methods. But on their own, they're often flawed. So what are these other methods? What are the actual building blocks of a better prognosis? Well, the evidence points to 3 incredibly powerful pillars. First, the patient's performance status, which is basically how well they're functioning day to day. Second, a specific set of clinical signs and symptoms that are really strongly linked to survival. And third, something we might forget about, just asking a colleague for their opinion. Let's just quickly define that first one. Performance status isn't some vague feeling about how sick a patient looks. No, it's a structured assessment of their ability to just carry out the basic activities of daily life. And it turns out it's one of the single most powerful predictors we have. And we measure it using 2 main scales you're going to see all the time, the ECOG and the KPS. The ECOG scale is really simple, just a 0 to 4 score that focuses on daily activity. The Karnofsky, or KPS, is a bit more detailed. It's a 0 to 100 scale. Both are incredibly helpful for just standardizing how you're assessing a patient's functional level. Next up, those clinical signs. Research has pinpointed several symptoms that are independently and strongly tied to shorter survival. We're talking about things like dyspnea, that's shortness of breath, anorexia, significant weight loss, and any kind of cognitive impairment. These are all major red flags. You should really think of these as a mental checklist you run through at the bedside. Okay, so we've got the building blocks, right? Performance status and key clinical signs. But how do you put them all together? Well, that's where validated prognostic tools come into play. They help turn all this raw data into a much more reliable estimate. The whole point of these models is to take the guesswork out of combining all these different factors. So instead of just trying to weigh them in your head, these tools give you a structured way to combine multiple data points into a single, more accurate score. It really helps reduce the impact of our own natural optimism bias. And for most patients with advanced terminal cancer, the gold standard, the one you really need to know, is the Palliative Performance Scale, or PPS. It is by far the most widely used and internationally validated tool out there for this exact patient population. This is a key thing to have in your clinical toolkit. So, what does the PPS actually measure? It's basically a 5-part assessment. You look at the patient's ability to walk, their general level of activity, how well they can care for themselves, their food and fluid intake, and finally, their level of consciousness. It's a really comprehensive snapshot of their functional state. Now, you might also hear people talk about the palliative prognostic score, or PAP. Here's a key difference to remember. The PPS is based entirely on what you can see and observe clinically. You don't need any labs. The PAP, on the other hand, does require lab results, and it also explicitly mixes in the clinician's own gut prediction, blending that objective data with the clinical intuition we were talking about earlier. All right, finally, let's look to the future a little bit. With the rise of big data in pretty much all of medicine, what role is technology like artificial intelligence going to play in prognostication? Well, the reality, at least for now, is that while AI and machine learning have tons of promise, they haven't yet proven to be clearly superior to the traditional models we've just been talking about. Yeah, they can analyze massive amounts of data from health records, but the actual benefit in day-to-day clinical practice, well, it's still pretty uncertain. So far, studies show that these AI models offer, at best, a minimal to modest improvement in accuracy over the tools we already have. Plus, there are some real concerns about their black box nature, a lack of transparency that can hide biases baked into the data. The bottom line is a lot more research is needed before these things become standard practice. So, we end here. Using tools like the PPS can absolutely make your prediction more accurate and help you move away from that 5.3x error margin to something much more grounded. But listen, that's only half the battle. The numbers, they're just the starting point. The real art of medicine begins with what you do next, using that information to have a clear, a compassionate, and an honest conversation. That is the skill that truly changes everything.